Dr. Maher. I'm a pediatric hematologist, and I'm going to be talking today about hemophilia and emergent therapies. So here are the learning objectives for my talk today. Number one is to recognize clinically significant bleeding symptoms and understand when to seek specialized evaluation and testing. Number two, compare available and emerging hemophilia treatment options, including extended half-life factor products, non-factor therapies, and gene therapy. And three, to use shared decision-making tools and resources to communicate personal treatment goals and preferences with healthcare providers. So here's an outline to show how I'm going to break down this talk today. First, I'm going to talk a little bit about the basics of hemophilia and the types of hemophilia. Then I'm going to talk about recognizing bleeding, specifically touching on joint health and menstrual bleeding. Then I'm going to talk about some of the prophylaxis medications that are available. So these are medicines that are used to prevent bleeding. So there are four main classes of medications: factor replacement therapies, factor VIII mimetics and rebalancing agents, and gene therapy. This really just serves as a brief introduction to each of these classes of therapy. And then I'm going to talk a little bit about shared decision making between people with hemophilia and their medical teams. So just so we're all starting on the same page, I'm going to talk a little bit about hemophilia. It takes multiple steps in clotting factor proteins in order for a blood clot to form. So if you have a cut or an injury, it takes many different clotting factor proteins and blood cells in order for a blood clot to form and the bleeding to stop. Factor VIII and IX are two of the essential clotting factors. And if a person has hemophilia A, their body doesn't make enough functioning factor VIII. And if a person has hemophilia B, their body doesn't make enough functioning factor IX. Hemophilia is caused by a difference in one of the genes on the X chromosome. So for hemophilia A, this is a variant in the factor VIII gene, and for hemophilia B, it's a variant in the factor IX gene. Males typically have one X chromosome and one Y chromosome. So if they have a hemophilia causing gene variant, they have a diagnosis of hemophilia because they only have one X chromosome. Females typically have two X chromosomes, and so females with a single hemophilia causing gene variant are typically referred to as hemophilia carriers. But it is important to note that about 50% of hemophilia carriers also have a diagnosis of hemophilia. So that is, even though they have two X chromosomes and one gene variant, they can have a low factor level and can have bleeding. Around 30% of hemophilia occurs in someone with no family history. We sometimes refer to this as sporadic hemophilia. So it is possible to have a diagnosis of hemophilia even though no one else in your family has it. Although in those cases, it is really important to consider whether someone in the family might have hemophilia that is not yet recognized, and testing in family members may be warranted. As a genetic disorder, hemophilia can be passed from a parent to a child, and so this picture on the right here shows some of the scenarios for how this can happen. So if a mother is a carrier of the hemophilia gene and the father does not have hemophilia, 50% of their sons will have, there's a 50% chance that each of their sons will have hemophilia, and there's a 50% chance for each daughter to be a carrier for hemophilia. And as I mentioned before, a carrier could also have the diagnosis of hemophilia. The second scenario shows that if a father has hemophilia and the mother does not carry the hemophilia gene, then there's a 100% chance that their daughters will carry the hemophilia gene, and they could also have hemophilia. And sons will not be expected to inherit the variant, so they will not be expected to have hemophilia. If a parent has hemophilia and a child is expected, the baby can be tested for hemophilia at birth. Typically this is done with at least a factor activity and sometimes genetic testing if the genetic variant is known already in the family, and can be done off, the testing can be done from blood collected from the umbilical cord at birth. And this is sometimes possible depending on how large the cord is and where the baby is born. But even if cord blood testing is not possible, testing can be done shortly after birth as well. If a person bleeds more often or for longer than normal, or they have a family member with hemophilia, then testing should be considered. Testing usually includes a factor activity level on the blood and possibly also genetic testing, and in some cases genetic testing is warranted even if the factor activity level is in the normal range. These tests should be interpreted by a specialist with experience in hemophilia diagnosis before a diagnosis is made or excluded. So for example, there are some situations where the factor activity may not be as reliable for diagnosis. For example, in women who are pregnant, a factor VIII activity will be or can be significantly higher than their true baseline factor VIII activity. And so those tests have to be interpreted with caution and may need to be repeated later to decide whether or not someone has a true diagnosis or not. Hemophilia is usually broken down into different severities, and the severity is defined by the baseline factor activity. So if someone with hemophilia has less than 1% factor activity, we usually call that severe hemophilia. Moderate is where the factor activity is between 1 and 5%, and mild hemophilia is defined as factor activity between 5 and 50%. Although we use these definitions, we know that factor activity does not match perfectly with the amount of bleeding someone has. And so some people with moderate or mild hemophilia have frequent bleeding and may benefit from medicines to prevent or treat bleeding, even though they don't meet the factor activity definition of severe. It's really important when someone has a diagnosis of hemophilia to know also whether they have a history of an inhibitor or not. So an inhibitor is a type of antibody that blocks or destroys infused factor protein. This is not something you're born with, but that develops over time in response to receiving a factor medication. Inhibitors are seen in about 30% of severe hemophilia A and up to 10% of severe hemophilia B. And although it's much more common in severe forms of hemophilia, there are some situations where people with mild or moderate hemophilia can also develop an inhibitor. Inhibitor can be, you can test for inhibitor with a blood test, and this test is done usually if factor medications stop working well to treat bleeds. It's also standard of care to offer screening for inhibitor presence at annual visits for people with hemophilia, even if there isn't a history of factor medications not working. Knowing whether you have an inhibitor or not is important to know which treatment options are available to you, because some medications don't work well if you have an inhibitor or expect it to not work well. In some cases, it is possible to treat or eradicate the inhibitor. The most common way this is done is something called immune tolerance induction, or ITI, and this is where people with an inhibitor receive high doses of factor medication and can make the level of the inhibitor decrease or go away altogether. ITI doesn't work for everybody, but it works for many people with inhibitors, and so it may or may not be an option if you have an inhibitor. So what kind of bleeding is seen in hemophilia? I think the classic type of bleeding that is seen, and if you look up hemophilia in a textbook, you'll see something like the middle top image here, which is depicting someone with a joint bleed. So bleeding into joints and muscles, this kind of deep tissue bleeding, is classically seen in severe hemophilia A and B. And we'll talk a little bit more about joint bleeding, but this is not the only kind of bleeding that we see. People with hemophilia can have nosebleeds that are either very prolonged or very profuse. We usually think of nosebleeds that last longer than 15 to 20 minutes as being prolonged. It is possible also to have head bleeds or bleeding into the brain, and although this is rare, spontaneous head bleeds can be seen and can be very serious. People who have periods and hemophilia can have heavy menstrual bleeding, postpartum hemorrhage or bleeding after childbirth. Excessive bleeding can be seen with surgeries or dental procedures, and this can be the first sign of hemophilia in some people. And it's also something we work really hard to prevent in people who are known to have hemophilia. And then easy bruising, which is not usually dangerous in and of itself, but can be a sign that someone has a bleeding disorder, such as hemophilia. So I want to take a little bit of time to talk about heavy menstrual bleeding, and I think that historically heavy periods have gone unrecognized as a symptom of bleeding disorders, and some doctors are not familiar with bleeding disorders in females, resulting in many females going undiagnosed or misdiagnosed. We know from the medical literature that women and girls who have bleeding disorders receive their diagnosis much later in life than men and boys, and many times this is because their periods are their primary bleeding symptom, and this may have not been recognized or asked about in a medical visit. If periods interfere with day-to-day life, last longer than 7 days each, are closer together than 21 days, or you're needing to change a pad or tampon more often than every 2 hours, this could be a symptom of a bleeding disorder. There are some online resources through the National Bleeding Disorder Foundation about bleeding disorders and bleeding symptoms in women and girls, and I've put some links down here below. This includes also something called a self-bleeding assessment tool, where you can answer questions about bleeding symptoms, including your periods, and get a sense of whether or not you have abnormal bleeding and whether you should ask for testing for bleeding disorders such as hemophilia. So then I want to also talk a little bit about joint bleeds. Joint bleeds are most often seen in severe and moderate hemophilia, and early recognition is really important in order to treat joint bleeds, and that's because joint bleeds, if untreated or recurrent, can lead to joint damage, chronic pain, and disability. And the way joint bleeds usually are recognized is pain and swelling in that joint, warmth, some people describe a tingling sensation, decreased movement, and inability to walk or bear weight. And in a young child, their refusal to walk might be the first sign of a joint bleed. Ultrasound imaging is used now by many hemophilia care teams to diagnose new bleeds, or also in order to detect joint damage in someone who doesn't have a history of recognized joint bleeds. At our center, ultrasounds are done by trained physical therapists, but there are other providers around the country who are trained in specific hemophilia joint ultrasounds, and these can be used, as mentioned here, in order to diagnose a joint bleed or for early detection of joint damage from potentially unrecognized joint bleeds. And this is a technique that can be really helpful when thinking about whether the medicine someone is using is working, because if they're having unrecognized joint bleeds leading to joint damage, then a discussion about switching medications may be warranted. So then I'm going to transition to medications for hemophilia. So medications can be used for different reasons. Many of the medications I'm going to talk about today are used for prophylaxis. So prophylaxis medications are medications that are used regularly in order to prevent bleeding. There are some people with hemophilia who are not on prophylaxis but use medicines only on demand. So on-demand medication means you're starting a medication once the bleed has started for treatment of bleeding. So people who are on prophylaxis often also should have a medicine to treat bleeding, but on-demand use only means the medication is being used only to treat but not to prevent bleeds. Prophylaxis is recommended for all people with severe hemophilia, and this is because we know that people with severe hemophilia A or B are expected to have 2 to 5 bleeds per month, and these bleeds can include joint bleeds, and so prevention of bleeding is really important. People with moderate or mild hemophilia may also benefit from prophylaxis, depending on their activity level and whether they have had bleeding before. And this need for prophylaxis can change through someone's life. So, for example, children who are born with moderate or mild hemophilia may not have any problems with bleeding when they are infants or toddlers, but as they get older and are growing and bearing weight on their joints and doing sports, for example, they may start to develop bleeding into joints and other kinds of bleeding. And so it may be that they start to benefit from prophylaxis later on. And so this need for prophylaxis can depend on someone's lifestyle and their growth and development. So the first class of medication I'm going to talk about is factor replacement therapy. Factor products replace what the body is missing. So this sort of makes sense. If your factor 8 is low, a factor 8 medication will make the factor level higher. So in hemophilia A, factor 8 products are used, and in hemophilia B, factor 9 products are used. These are all given intravenously or through the vein, and here you can see a picture of someone giving themselves an intravenous infusion. This is a peripheral infusion, but factor replacement is sometimes given through a line in the chest, also called a port. So factor replacement is used for treatment of bleeding, but it can also be used for prophylaxis if it's given regularly. If someone has hemophilia with an inhibitor, it may be that factor medicines don't work because the inhibitor will inactivate the factor protein when it's infused. And so in those cases, an alternative may be needed to treat bleeds. And generally, these alternative medicines are called bypassing agents. When a factor infusion is given, the factor level will rise to a peak level, and then it will start to fall over time. And so for factor replacement that's used as prophylaxis, people will have to infuse on a regular basis in order to keep the factor level higher than their baseline. Extended half-life factor products, or EHL factor products, are modified factor protein that lasts longer in the body, and this means that they can be given less often and still protect people from bleeding. So here in the picture on the right, you can see how the factor level goes up and down with time. The little blue arrows along the bottom represent the times when a factor infusion was given. And the extended half-life factor products, you can see, are given less often while still keeping the levels above the desired trough level. So the trough level, which is the lowest level during the course of therapy, is really important, and we know that the higher the trough factor level is, the better you are protected from bleeding if you're using factor products for prophylaxis. With the newer extended half-life factor products, dosing can be weekly or sometimes even less often in adults. There are multiple extended half-life factor 9 products available. These have been around since about 2014. But achieving this truly extended half-life has been more elusive for factor 8 products. And recently in 2023, a factor 8 product called FNS Octacog Alpha, or also known as Altuvio, was approved for hemophilia A prophylaxis. And this one is called out specifically on this figure to the right, showing that with weekly dosing, the factor 8 activity level is still very high throughout the week and is over 40% for the first 3 or 4 days. So this is the first factor 8 product that has been able to achieve these higher levels for extended periods. And Altuvio is typically given as weekly IV infusions for prophylaxis. So then what are the pros and cons of factor replacement therapy? So one of the pros is that factor products replace what is missing. This is nice because the mechanism is very similar to your body, just making more factor 8 or 9. And this allows us to monitor the factor activity with the lab tests that are available in most places, and to aim for what we know are normal ranges with bleeds, surgeries, and sports. So this can allow us to tailor the factor infusions to pretty much any situation. Factor products that are used to prevent bleeding can also be used to treat bleeding, so this can be simpler in the sense that you have one medicine at home that can be used to both prevent and to treat bleeding. Some of the downsides of factor replacement therapy are the peaks and troughs, like I showed in the last slide. So although it can be helpful to tailor the therapy to certain situations, it can limit spontaneity in terms of if we want factor activity levels to be high during sports participation, for example. It may be that if factor infusion is given early in the week, that later in the week those activities may be harder to do and require additional infusions. There's also a high burden and cost of IV infusions, so it's not for everyone. Some people can, for some people, peripheral infusion is something that can be learned and easily done at home, but not everyone has good venous access, and this could be difficult. In some of those cases, people may need a central line or a port, and those come with their own risks, including infection and blood clots. And then factor products are not effective for some people with hemophilia with inhibitors if the inhibitors are of high intensity, or what we call high titer inhibitors. The next class of medications I'm going to talk about is the factor 8 mimetics. So these are not factor, but they mimic the function of factor 8. They are bispecific antibodies that bind to factor 10 and factor 9, which is the job that factor 8 does in the blood clotting cascade. And they can be used for prophylaxis in hemophilia A, so for prevention of bleeding in hemophilia A. These medicines are given subcutaneously or under the skin instead of into a vein. So this has made a really big difference for people who don't have good venous access. And then the dosing schedule can be weekly, every 2 weeks, or sometimes once a month, depending on the medication and someone's weight. And the factor 8 mimetics, while they can be very helpful in preventing bleeding, they cannot be used to treat bleeding. So the first approved factor 8 mimetic was emicizumab, or Hemlibra, which was approved in 2017, and there are many people with hemophilia A now on this medication. There is also a medicine called Mimate, which is another factor 8 mimetic, which is likely to be approved later this year for hemophilia A prophylaxis. And then just to call out one of the other factor 8 mimetics that's currently in clinical trials called NXT007. So these, all of these different medications are factor 8 mimetics that can work really well for prophylaxis in hemophilia A. So what are the pros and cons of the factor 8 mimetics? So factor 8 mimetics substitutes for what is missing. So at least the mechanism is similar to factor 8, and the subcutaneous administration has been really helpful for many people, is usually easier than giving IV infusions for folks. Factor 8 mimetics can be started as early as birth, and there are some children who have been started as early as birth on emicizumab already and have been on that medication for prophylaxis ever since they were born. Factor 8 mimetics work for hemophilia A with inhibitors, so unlike factor prophylaxis, the inhibitors don't recognize the factor 8 mimetics as foreign, and so although it mimics the function of factor 8, the factor 8 mimetics structurally are very different and can work for people even if they have an inhibitor. The downsides of factor 8 mimetics: they don't treat bleeds when they happen, at least not the ones that we have currently available. And so factor medication is still needed. So if you are using a factor 8 mimetic medication for prophylaxis, you typically also need a factor medication at home in case of bleeding. They don't provide enough protection from bleeding with surgeries, so factor may still be needed around the time of surgeries or procedures. They're not effective in hemophilia B for prophylaxis. And if you have hemophilia A with an inhibitor, there are some bypassing agents, specifically the prothrombin complex concentrates, that if used together with factor 8 mimetics have been associated with increased risk for blood clots. Next slide. So the next class of medications I'm going to talk about are the rebalancing agents. So rebalancing agents do not replace or mimic the function of the missing protein, but instead they decrease the activity of an anticoagulant protein. So if you look at the figure below, you can see that in hemophilia, what is missing is a procoagulant protein, so there's not enough factor 8 or factor 9. And so instead of replacing that, if you could remove the activity of some of the anticoagulant proteins, you could restore the balance of the blood clotting system for someone who has hemophilia. So the first kind of rebalancing agent I'm going to talk about are the anti-TFPI medications, or anti-tissue factor pathway inhibitor medications. So TFPI is one of these natural anticoagulants in the blood, and there are 2 medications in this category that are already approved for hemophilia prophylaxis. The first one is concizumab, or Elhemo, which was approved in 2024 for people greater than 12 years old who have hemophilia A or B with or without inhibitors. This medicine is given subcutaneously, so under the skin, and is given daily. This medicine does require some lab draws for monitoring of drug level. The first drug level is drawn 4 weeks after starting the medication, and that's to make sure the drug level is within a target range. And in some cases, the medication dose has to be modified for people if the drug level is not in the right range. The second one on here is marstacimab, and this medication was approved also in 2024. for those greater than 12 years old with hemophilia A or B without inhibitors, although it is likely to be approved also for those with inhibitors eventually. This medication is given weekly, and there is currently no need for blood draws for drug level monitoring for this medication. Next slide. The second type of rebalancing agent that I'm going to talk about is something called an antithrombin lowering medication. So antithrombin is another one of the natural anticoagulants, and so if you could lower the amount of antithrombin in the blood, then you can also restore the blood clotting balance in someone with hemophilia A or B. The medication in this of this type that is approved is fitusiran, also known as Hemophilia, approved in 2025 for people greater than 12 years old with hemophilia A or B with or without inhibitors. This medicine is given fairly infrequently, so only monthly or in some cases every 2-month dosing. This medication also requires some lab monitoring. It requires a baseline antithrombin level to make sure your antithrombin level isn't already low, and then repeat levels for dose adjustment. So antithrombin levels need to be obtained at months 1 and 2, and then other time points going forward depending on whether or not you need dose adjustments. This medicine is associated with some elevated liver enzymes, so some liver effects, and can also be associated with gallbladder inflammation. So if you have a history of liver disease or gallbladder problems, it may not be as attractive of an option. But most of the people in the clinical trials who had effects on their liver from this medication, in most cases it was mild and did not require discontinuation of the medication. Next slide. Another important topic for the rebalancing agents is safety, and that's because in the clinical trials of all of these rebalancing agents, some people receiving the medicines had serious blood clots. In many cases, these were people who were also receiving treatment for a bleed or treatment ahead of a surgery or procedure. So it's important to discuss the potential risk for blood clots before starting one of these medications. Since those events in the clinical trials, the risk for blood clots with these medicines has decreased significantly, and that's because of the monitoring that is now done of the drug levels or drug activity for concizumab levels and antithrombin levels for fitusiran, for example. It is also important to note that a reduced dose of factor medication may be needed for treating bleeds if you're on one of these medications. This is another one of the methods used to decrease the risk for blood clots. If you are considering starting one of these rebalancing agents for prophylaxis, it's important to review your emergency bleeding plan because it may change depending on which prophylaxis medication you're on. Next slide. So what are the pros and cons of the rebalancing agents? For pros, these medications can be used for hemophilia A and B with or without inhibitors, so really works for any type of hemophilia. They are given subcutaneously, so again, don't require IV infusions, and they are the first subcutaneous options for patients for prophylaxis for patients with hemophilia B. And I think also really importantly, for people who have hemophilia B with inhibitors, for whom the extended half-life factor products do not work, this is really a significant advance in prophylaxis for this group of people because there have not been really good options for prophylaxis for hemophilia B with inhibitors before the rebalancing agents were available. What are the downsides? The rebalancing agents, much like the factor VIII mimetics, do not treat bleeds, and so a factor medication is still needed for that. Similarly, they may not provide enough protection from bleeding with surgeries, and as mentioned, some of them require lab monitoring and dose adjustments, so there is a period of adjustment after starting the medication that may require multiple lab draws. And then, as I mentioned, there is an increased risk for blood clots and ways to decrease that risk, so it's really important to consider for each individual whether blood clot risk is important for them. Next slide. Next, I'm going to talk very briefly about gene therapy. So the goal of hemophilia gene therapy is to restore normal factor VIII or factor IX levels in the body. And the approved gene therapies currently for hemophilia deliver a healthy copy of the factor VIII or factor IX gene using a viral vector. So this is done using a single IV infusion, and the medication directs a healthy copy of the gene to the liver cells so that more factor VIII or factor IX can be made. Hemgenix is a gene therapy approved for adults with hemophilia B, was approved in 2022. And this is the only gene therapy currently available outside of a clinical research trial. Although there are 2 other gene therapy products approved, they are not currently commercially available. Next slide. What are the pros and cons of gene therapy? I think, gene therapy is a single IV infusion, and when it works well, carries the potential for a sustained factor level in the normal range, which means protection from bleeding without any regular use of medications, so no longer needing any prophylaxis medications at all. The downsides are some risk for liver inflammation because the current gene therapies for hemophilia are liver-directed. There is some risk for elevated liver enzymes, and this may need to be treated with courses of steroids. For Hemgenix, approximately 20% of patients who received gene therapy needed some treatment for liver inflammation for a period after receiving gene therapy. There are at least weekly visits for the first several months after the gene therapy infusion, and this is for monitoring for liver inflammation and monitoring of factor activity levels. And then final factor levels are variable, and although it was very rare for Hemgenix, some people need to go back on prophylaxis. And for Hemgenix, about a third of people who received the gene therapy had final factor levels in the non-hemophilia range, so they had levels high enough that over 40%, which is considered in the non-hemophilia range. And I think about 95% of people no longer needed prophylaxis after receiving gene therapy. Next slide. So now that we've gone through briefly the different treatments available for hemophilia, you may have noticed that there are many new prophylaxis medications approved in the last 5 years. So it's more important than ever to understand the treatment options and discuss your treatment goals with your medical team so they can help make a treatment plan that works for you. Next slide, so you're gonna click forward a few times. So here you can see there is a lot of advertising out there for these new medications. And they mention things like higher factor levels for longer, there's one more click, I think, less frequent dosing, thank you. And a lot of these newer medications are given subcutaneously with these pen devices that are very convenient and less painful. And so when you're seeing all of these advertisements out there, it's really important to bring back any of your questions to your medical team and discuss whether these medicines could, if they could work for you and if they're appropriate. Go ahead, next slide. Okay, so, and next slide again. So next, I'm gonna talk a little bit about shared decision making and what is shared decision making. Next slide. So first I have a question for anyone who is listening to this talk, and that is to think to yourself if you have ever left a clinic visit feeling like your priorities were different from your medical team. And I think a lot of people have had this experience. A lot happens. You have to get to your visit and park and get into the clinic room, and people ask you a bunch of questions. And sometimes you might leave feeling like I didn't even really talk about what I wanted to talk about. Next slide. So what is shared decision making? This is, is something, is a term really that means that the medical team's job is to provide information about treatment options, potential future treatment options, and provide their expertise on hemophilia. But the person with hemophilia also provides their goals, preferences, and experiences, and the decisions about the treatment plan are made together and not just by one person. So this takes a lot of time and takes, may take more than one visit, and really means that you have to have a medical team that will take this time and sit down and listen to you as well as talking. And so I'm going to talk next about thinking about this ahead of time before a clinic visit. And next slide. there are some factors that we could talk about in determining treatment options, so I'm going to just touch on that first. And some of these are objective, so your age, what type of hemophilia you have, A or B, what severity of hemophilia, so what your baseline factor activity is, what's your history of bleeding, whether you have a history of inhibitor, whether it's active, that's your inhibitor status, whether you have a history of blood clots or not. But then there are also some things that are more subjective, so whether there's a preference for IV or subcutaneous medications. Some people have a higher tolerance for risk or unknowns. Some people are earlier adopters of new therapies, even though there might not be as many years of experience and data about how these medications work for people. For some people, it may be hard to follow a certain dosing or lab schedule because of work or travel. People have different lifestyles, so different physical activities and work demands. And then family and caregiver support is really important for everyone, and especially children. Who is going to be giving the medicine? Who's going to be making sure that that the lab schedule or dosing schedule is possible? And so having family and caregiver support is also key here. Next slide. And then you can also consider what are some key attributes of the different treatments. So I've listed some attributes along the left, but some of those include what is the treatment class, when was it approved, what's the route of administration, is it IV or subcutaneous, how often do I need to give it, so that's the treatment routine, is there a need for more than one medication at home, so some people really value having a simple plan that is a single medication and not a prophylaxis medication, and also needing factor for emergencies, and then what is the need for lab monitoring, which could be more or less intensive. Next slide. So what tools are available to help you with shared decision making? I think there are some things that everyone can do, like writing down your questions before your clinic visit, reading about the different medication options ahead of time, trying to decide what your goals are. But the World Federation of Hemophilia has this online shared decision making tool specifically for hemophilia, and so I want to call this out here and share the link. And this is an online tool that you can use to help you with shared decision making, specifically in hemophilia. Next slide. Okay, so if you go to the website and the link there, it has a sort of roadmap that outlines this tool. So it starts with questions about how hemophilia impacts your life and what your values and preferences are. And this is sort of like a kind of homework that you can do for yourself. And after you answer those questions, and there's a place to type in your answers, it has some educational materials about the different treatment options, including comparison charts, which are really great. So they compare the different types of treatments available for your type of hemophilia. And then you can have conversations with family or others. And then using all of this information, you can prepare your answers and your discussions to visit with your healthcare provider. And that allows you to have a more meaningful conversation with your healthcare provider and take time to consider your options. And it may be that a decision is not made at the visit, and you arrange a follow-up visit in order to confirm your decision about treatment. Next slide. So these questions are pulled directly from that tool, but they are some of the questions that you can ask your medical team if you're looking for questions. What treatment types are available to me? Which specific products are available? What's the process of switching to a new treatment or switching back if I don't like it? Are there any expected future treatments I may be a better candidate for? And this may include medications that are in clinical trials. What will happen in the event of a new bleed on this medication? So this speaks to how some of the newer prophylaxis options require alterations in your emergency bleeding plan. And what should I know about the side effects or risks with the new treatment? Okay, so with that, I'm going to stop. Next slide. And I'm happy to take any questions. Thank you. Yeah, so
inhibitor therapy. In the past, I think that used to be used quite often.
Yeah, great question. So immune suppression used to be used more often in people who developed a high titer inhibitor. But usually what we start with in immune tolerance induction is high and frequent doses of factor medications, because for many people that's sufficient to eradicate the inhibitor. It can take months, and very frequent infusions, which can be very burdensome for people. But we usually try that first without using immune suppressive medications because of the side effects of immune suppression. For some folks who continue to have high titer inhibitors after the factor, intense factor replacement, then yes, occasionally we still use medications like rituximab or Cytoxan, but I would say that's becoming less and less common over time now that we have these new medications that work even if you have an inhibitor, and that would really be a decision that you make with your medical team. I would say many people would prefer to avoid that, and I would say in this recent years, I can't think of anybody who has chosen to do that in my practice. But of course, it is still possible if eradication of the inhibitor is considered to be really important for someone. Yeah.
Especially in low-income countries or low-resource communities where these new treatments are not available.
Yeah.
And Cytoxan is super cheap. Do you think that could still be utilized in those
It's a good question. I think that you have to balance that in the low resource situation, that if someone were to develop a severe infection, what's their ability to get quick emergency care for possible sepsis, for example, right? So I think you have to balance the risks and benefits there, and decide whether the risk of a serious infection, increasing the risk for a serious infection, is outweighed by the benefit of now being allowed to use factor for your medication, right? So if they have access to factor and not one of the non-factor therapies, maybe. But yeah, I think that you would have to balance what access you have and to what, because you still are putting yourself at risk for serious infections.
Sure.
Yeah.
For gene therapy, some patients, it's an exciting new drug, and it is great for so many patients. But some patients still require replacement therapies for long, right? Do you think you could repeat the gene therapy, give a second dose?
Yeah, so that's a great question. I think the clinical trials that have been done for hemophilia gene therapy excluded those who had AAV antibodies. And what happens when you receive an AAV gene therapy is you develop antibodies to the AAV vector. And so, at least as of now, people who have received the available gene therapies are not being considered for repeat dosing for that reason. But in the future, who knows? In the future, it may be that these antibodies can be overcome by higher doses. But that's kind of a hot topic in gene therapy. Is if I get the gene therapy that's available to me now, if a newer version comes out, or if I need a repeat dose because the factor levels are waning, will that be something I can do? And as of now, someone who has already received one of the available gene therapies would not be a candidate for repeat dosing for that reason, because those patients were not included in the clinical trials. So whether or not it will work, it is thought that it will not work.
Yeah, but scientifically thinking, you can always give some of the lymphocyte depleting drugs temporarily for several weeks and give gene therapy to allow for tolerance.
Yeah, and I think these are some of the important questions that we don't know the answer to yet. Yeah.
Sure. Thank you.
Yeah.
In your presentation, you had that question for patients about, have you ever felt like leaving there's a difference with your care team having different preferences? Could you maybe give some examples of what that looks like when care teams and patients, you find that they do have different preferences?
I think in a busy clinic visit, sometimes the doctor or other provider will come in and talk about how have you been doing, and what medications are you on, and let's refill those today. And there may not be space left for someone to speak up or ask questions, or people might feel shy to do that. And then what tends to happen is they move forward with the same plan as they came in with last time, which may or may not be working. I mean, to say that some people are on a medicine for prophylaxis that works really well and they don't want to change, and so that's fine. That may be the way they wanted things to go. But if they are interested in a change or talking about the new therapies, it's really important to have the time, which requires a long enough clinic visit and a good relationship with your medical team, to pause. And I think some people are more or less good at pausing. It can feel uncomfortable, I think, for there to be quiet space in a conversation. But I think that can be fixed by, we need providers to be good at this and have education about shared decision making so that they're pausing enough and asking questions. And also people with hemophilia coming to the visit to come armed with those questions, so when the space and time is there, that they they know what it was they wanted to ask. So I think both sides, need to be prepared for the visit ahead of time, which is easier said than done. If that makes sense.
You mentioned, you could come up with more questions for patients. Are there any off the top of your head that you would want to bring up for them to consider?
Yeah, I guess one question that can be worth asking yourself is, what is, when you think about your therapy for hemophilia, what's the most important thing for you? Is it, I'm really, and so there are a list of things that we could come up with. So for example, I'm really active in playing sports, and it's really important that I protect myself from bleeding with injuries. Or for some people, I want to protect myself from bleeding, but it's also really important to me that there are many years of experience with this medication, so the safety profile is really well known. Or some people, could ask if do you think you're someone who's an early adopter of a medication that's been recently approved or not. I think that's a kind of a question that you could ask yourself. So yeah, I think it's a sort of rank, some of those attributes of the different therapies and rank them in order of importance for yourself. Like protection against bleeding is the most important for me. It's most important for me that the medicine not be given IV because I really don't like IV infusions. So to sort of rank among those different attributes, which ones are the most important for you.
On the caregiver side, maybe particularly with your focus on younger patients, maybe that shared decision making, like how can caregivers, I'll let you take it wherever you want to go with that, but something related to the caregiver role. Yeah,
I think the caregiver role changes throughout the child's growth, right? And I think when they're a baby, when you have a new baby with hemophilia, really you're making these decisions along with other caregivers or other family members or loved ones. As the child grows, it's really important to involve them in an age-appropriate manner in that decision. And I think especially in adolescence, that's a time when some additional discussion to involve them as early as you can, because what we do see, and this is probably true in many specialties, that when children become teenagers and then become adults and are responsible for their own care, if this responsibility isn't transferred to them over time, then that can be a shock when they all of a sudden are over 18 and they're the ones having to take on some of the responsibility for their care. And so I think that transition of care is a really big topic, including in hemophilia, that we talk about things early and often and understand the language and the appropriate amount of discussion for a child at whatever age they're coming. So we usually do annual visits for hemophilia, annual medical visits, and each year is a little different, especially through the teenage years, in terms of hopefully the caregiver sitting back and allowing their child to do some of the talking, which can be really hard.
That's a great question, because I'm going through that right now with a 19-year-old who over the last couple of years I've been there, right? And we've been able to support and ask the right questions and also receive the answers, because we can give them right?
Yeah.
Things of that nature. And as he was right there, 17 to 18, so it was a quick transition to 18, where now, you know, the choice is theirs to be in the room, to listen. So when we leave, how do we have that information in our back pocket so that we can make sure we go home and have the right conversations, that also if we weren't in the room, that you know, that we're answered for him, so we're on the same page. I think that can be difficult.
Yeah, and you know, we have rules. When someone turns 18, unless they give permission, we're not allowed to share information with their parents, and it's a very stressful time. Because
Absolutely.
because parents work really hard to protect their children, and then all of a sudden, if the child decides they don't want them in the room, which is a valid choice, it's very anxiety provoking. So that's why, I think allowing the child to be in the room alone, even potentially earlier than 18, and then to leave and to talk to their parent, and the parent can still ask us what happened. You know, within some limits. I mean, there are some things we still can't disclose to parents. I think the earlier the better. We have transition, what we call transition timeline, where we start as early. We start at 12, where we start tracking at our center and at many centers, where we start tracking, like, what questions did we ask the child and what could they answer? Like, even something as simple as what is your bleeding disorder diagnosis? What's it called? And asking that question as early as possible. We start to track how they're doing as early as 12, because by the time they're 18, in some ways, it's too late if we haven't started doing that.
Yeah, and it's a true collaborative partnership between everybody, right?
Yeah.
Parents, patient,
children.
and doctors. And so the earlier you can do that, and they can see and learn from that as well, and accept that, so that when they get to that age where we've been blessed so far, luckily, that we're continuing to be involved, but I do fear. My wife and I were talking about that one day, where he's like, he just say, I'm good, and it's like, how do we then partner accordingly to what's best for him? Thank you for answering that. I appreciate it.
It's a really big, it's a really big deal for everyone.
Is this deck available to those that are involved, that were involved in this call, so we can go back and reference some of this stuff?
We're gonna put it under review, and then some version of it will be available.
Excellent.
Is there anything else you were hoping to cover that?
I don't think so, except, I'm sure that this deck will be out of date soon, because there's new medicines under investigation for hemophilia, many of them, and there are gene therapy trials open, and so if you're watching this video, even in a couple months, there may be changes to what's available, or what's available at least through clinical trials, and many people with hemophilia decide to participate in clinical trials. So even if you're watching this and it's sort of a primer for what's available today, in June 2026, if you're watching it, many months later than that, it's also important to talk to your medical team about, what medicines are available or what clinical trials are open, because it is likely to change even in the coming months or year. So I guess that's the last thing that I would add.
Yeah. And you'd mentioned like an annual visit, like what's the cadence of, somebody checking in with their team, and if they hear things on the internet or in their own research, or they're part of a patient support group. I mean, we're lucky now to have video visits, so I offer video visits anytime. So if someone hears something, or they want to have a discussion about a new medication, or they think what they're doing is not working, we can have a quick video visit, or not quick, video visit at any time. But the annual visits, we call those comprehensive visits, and at my center, which is a Hemophilia Treatment Center, so Hemophilia Treatment Center is a federal designation, meaning we have certain services available, including physical therapy and genetic counseling and all these things. The comprehensive visits, it's standard for us to offer them yearly. That's a good time to have a shared decision-making conversation, because those visits are scheduled longer. Ours are typically around 2 hours. But if you can have a shared decision-making conversation anytime. You just reach out and we'll set up, usually if it's mostly talking, it will be a video visit usually, because most people prefer that, although it can be in person.
So really that could be any time if you reach out, but I would say the annual visits are when, you know, the whole team is typically available. And some of the questions in shared decision-making conversation it may be helpful to have the genetic counselor or someone else around. So I think annual visits are pretty standard of care, at least in severe hemophilia, and we offer them for all severities. But the cadence could be anything that someone wants, really. We could offer a visit anytime in between. Yeah.